And thanks to you all for turning up bright and early on this last day of the conference. So my name's Gavin. I'm a statistician and a geneticist. I've worked in the field of human genetics for several decades now. But I'm here today representing a company that I co-founded, Genomics PLC. We're a UK-based company, and what we tried to do is to understand genetic risk in its fullest sense, and to use that information across a range of different markets, working with partners from healthcare providers through to pharmaceutical companies, through to employers who are interested in sort of providing offers to their employees. So we're interested in the broadest sense of how we can translate an understanding of risk, which has been developed to an astonishing degree over the last 20 or so years within this field, into applications which can genuinely transform healthcare. So of course that's the motivation, and what I'm going to talk about this morning is to really focus on this question of how we might be able to use such information in the context of healthcare fairly broadly to advance essentially the science of prevention. How do we use the fact that we can now understand quite a lot about the risks that each person carries within their genome, and the science has got to the point where we can actually read that with a pretty high degree of accuracy. How can we translate that into something that is genuinely making a difference? Now, of course, there are many, many different aspects to the challenges of that implementation journey. I'm not going to be exhaustive, and I think up front I should say the journey hasn't finished. We're not at that point today. The science is amazing. There are some really important pieces of implementation that I think we're beginning to make progress on, both as a company but more broadly as a society and a community. But there are clearly still challenges out there. So I'm going to talk a bit about some of what I see as the key challenges, how we as a company are trying to overcome some of those, some of the themes that I think are still emerging as key things that for us all to focus on over the next few years. And then I'll finish with a bit of a look forward to where I see the field going. Now, I am going to assume that because you got up bright and early on this day and you've made your way to this room, that you know what a polygenic risk score is. Is there anyone in this room who doesn't know what a polygenic score or a polygenic risk score is? Because I'm not going to do much background. I'm going to assume that most of you are familiar with this idea, just for a couple of minutes to sort of make sure we're on the same page. Briefly, the idea that I'm going to be focusing on is the sense that we can now use technologies, SNP arrays or whole genome sequencing, it doesn't really matter, to read a person's genome or to get a good sketch of their genome in a high throughput manner, to use the fact that there have been vast studies carried out by the academic community typically around a broad range of common diseases, from common cancers to cardiovascular disease, to metabolic disease, to heart disease, and actually into many of the deeper and darker and rarer aspects of human disease as well, such that we now understand a lot about the major genetic drivers of risk, and that we can put that information together in a very simple way, typically, so that when I'm faced with a genome, I can read information about risk that is inherent in that genome. Typically, there is a single number that I can convert all of that information into, which tells me something about your relative risk, typically, for getting that disease at some point in the future. There are clearly equivalent scores that I can calculate about quantitative traits, so there the idea isn't risk, it's more a sort of expected trait value, but I'm typically going to use PRS as the term throughout, so polygenic risk score. So that's the background, and I wanted to give you a sense of where I think the science is at. And the science is actually really kind of pretty amazing, I think. So let's take breast cancer in the UK as an example. So in the UK, routine mammograms are offered to women in their from the age of about 50. So they're not offered routinely in their 40s. And the reason is that the disease is less common in this group, and so it's been deemed that mass screening is not cost effective in that. There are trials looking at modulating that a bit, and I'm sure many of you are aware that in the US the guidelines have very recently changed to extend into the 40s. But actually in the UK it's not routine. But in this group, in the 40 to 50-year-old women, about 8,000 new breast cancer cases are diagnosed each year. And of course, we all know that symptomatic disease typically has a worse outcome and is more expensive to treat. So hospital systems, the payers, the providers would like to be able to identify these women, of course, before they reach the symptomatic stage. So where do polygenic risk scores come into this? Well, breast cancer and the risk that women carry for breast cancer is one of the poster children of genetic research, essentially, the common genetic disease movement. The studies that have been carried out on this are now huge in terms of their sample sizes. Still quite a long way to go to fully capture heritability, but maybe something like 30% of heritability has been captured for breast cancer so far. And what we can do is to use that information to calculate polygenic risk scores for breast cancer for women, and we can look at where the risk for those women sits compared to, for example, the risk that you'd carry if you had a mutation in one of the known cancer genes. Now in the UK, there are guidelines set up which were essentially derived from thinking about risk that is carried by carriers of some of these mutations, so that if a woman has a lifetime risk of at least 17% of breast cancer, she's considered moderate risk, and greater than 30% is high risk. And actually, if we look at the polygenic risk scores, it turns out that about 15% of women have a level of risk from their polygenic risk scores that's in this moderate to high category. So that's women who, if they had been carriers of a mutation, would have a different treatment. They would get screening earlier, they would get screening more frequently. This has been designed and set up to catch early breast cancers and to catch women who are much more likely to be unfortunate and get the cancer. So the science is at the point where we could say, okay, let's adopt the idea that polygenic risk scores for breast cancer could be used to identify women who would benefit from earlier and more frequent screening. So let's think about stretching it, taking women in this high-risk group, moderate to high-risk group, into their 40s. If we offered screening to such women in the 40 to 49 age group, you'd pick up about 30% of the cases in this currently unscreened group. So it's about 15% of the women, 30% of the cases, roughly twofold enrichment. And what's interesting is that at the population level, of course, you may not be too surprised, that this accounts for a vastly greater proportion of all breast cancer than that is caused by mutations in these well-known genes. And that's what the chart on the right shows. Oh, I was told I could just point it there, but it doesn't look like I can. Never mind. You look at the blue and pink chart on the right, second bar in, this is breast cancer cases in women aged 40 to 49. Red are cases among carriers of mutations in some of the well-known breast cancer genes. Blue are breast cancer cases in this group of women with the high polygenic risk. And you can see that at that population level, although the fold increase from PRS is less than the fold increase from being a carrier, the actual fraction of disease explained is considerably greater. So this sounds great. This is kind of some of why I started the company and why I joined it full time, is that the science is at a point where we can do this, and indeed there are various studies around the world looking at how you can start to think about implementation. But why aren't we doing this today? Why hasn't the community, the clinical community, rushed to adopt this? Why isn't this something that we are routinely offering today, given that the science has got to this point? So I'm going to talk about some of the challenges that I see in terms of this pathway to adoption, and I'm going to focus on 5 of them. I'm sure it's a much longer list, and I'm sure many of you will have your own lists, but there are 5 that I want to pick up. Now, the first is to do with what is an actionable level of risk? What is the level of risk that we can measure from your polygenic scores that should be or could be considered actionable? So let's have a look at the chart on the right. This is the cumulative incidence in the UK Biobank of coronary artery disease in men, here stratified by their polygenic risk, actually for cardiovascular disease more generally. And what you can see, the red line is people in the top 3% of that risk. The cyan line is the median risk, and the blue, the dark blue at the bottom, is the low risk, the 3% at the bottom of that risk distribution. You can see there's a huge difference in these risk profiles. So, for example, at age 65, there's a 20-fold difference in the cumulative incidence of CAD between the high and the low risk groups. Or put a different way, if you happen to be in the high-risk group, you would reach the level of risk of a typical 65-year-old something like 15 years earlier. Now, these are pretty scary. I kind of would like to know where I sit in this distribution. So we know that the science is good. I've kind of already said this, and we know that we can read the information, we can quantify it, we could potentially even act on it years before any symptoms appear. So point 1 is we can read that risk. And it's not just breast cancer, it's not just coronary artery disease, it's all sorts of traits. So that's the first point. But of course, genetics is not enough. I'm a geneticist, I get very excited about genetics, but clinical practice clearly has been thinking about risk and the factors that make people more or less likely to have a particular disease for ages. And if it turned out that essentially all of the risk in this that differentiates the red and the blue lines here was risk that I could actually read in a much simpler form, for example, by reading your LDL level or just looking at your age or something like that, then it would be somewhat pointless. So we need to know how much genetic risk adds over and above other factors. And so systematically we've been looking at how PRS affects risk for a broad range of diseases compared to the other factors which are known to be relevant in determining that risk. And what we find is, although it's not universally true, for many diseases, genetics is the single biggest risk factor. And in fact, for a substantial number of diseases, 4 on the right, for example, even if you put all those other risk factors together, genetics still is stronger than those other factors put together. So it seems to be, at least for diseases like breast cancer, prostate cancer, glaucoma, colorectal cancer, genetics really is a game changer in terms of our ability to understand risk. So that says that genetics is powerful, and actually, for many diseases, it's really much more powerful than anything that we've been reading before. And then this slide, I think, is one that is particularly striking, which comes back to that level of that question of how do we define something as being actionable. And the chart on the right shows, again, the cumulative incidence of coronary artery disease, stratified in this case by red, and that's kind of the key line to look at, which are red are the carriers or mutations in familial hypercholesterolemia genes. So these, we don't have, in the UK, we don't have a national screening program for these, but there are lots of programs out there which are trying to find more of these carriers because they have a really very elevated incidence of cardiovascular disease throughout their life. So there's a program out there, there are programs out there trying to find more of these people. It's about 1 in 500 people carry such mutations. So we're putting a lot of effort into finding these 1 in 500. Now for polygenic risk score, where's the sort of percentile of the distribution that matches that? Turns out that 8% of the population is walking around with a polygenic risk score that's equivalent in risk to a typical mutation in one of these FH genes. That's a huge number. You know, that in terms of a multiplier, that's another 20-fold increase compared to the carriers of these mutations. And that's today as these polygenic risk scores get better and better and better, and we know for something like CAD, actually we've still got a long way to go in terms of heritability, explaining heritability. So as the data sets get bigger and bigger and bigger, that it will go from 8% to 10% to more. So we're at a point where the science says we can find people with levels of risk which are comparable to the risk seen in carriers of mutations for which there are active programs out there trying to find such mutations. So that we can find those risks. Now, the two charts I've shown were in UK Biobank. It's obviously a brilliant resource, but it's not the whole world. Clearly, one of the things we need to do, and I'll touch more on that in a second, is around validating the statement that we can learn about risk and we can find people with equivalent risk no matter where they are in the world, or UK if we're looking at UK deployment, US, wherever. So we need to prove that these technologies aren't just unique to UK Biobank, they work across the world. And so one of the things that we've done as a company, and I'm sure many of you do this as well, is that we partner with groups across the world to demonstrate that the tools and technologies that we develop to measure risk transfer across contexts. There's the issue of transferring across ancestries, genetic ancestries and ethnicities, which I'll talk about a bit more. But in terms of, for example, European ancestry people in the UK or Finland or the US, then really the technology has got to a point where it's pretty stable over those different contexts. So we consistently find people of high risk no matter of where they are across the world. So that's the first challenge. I should be a bit faster with the others. And what I think that means is we're now at a point where the science says, yep, we can find people with risk that's pretty comparable to the risk seen in carriers of mutations where we already have programs. So, hey, why don't you adopt this? The second problem, however, reflects perhaps more on the cardiovascular disease, because although for things like breast cancer and colorectal cancer, genetics really dominates the risk that we can read today, for other diseases it's a more complicated picture. There is an interaction, there's a lot of information in genetics that's captured by other things. So I think one of the big questions that we have to face as a community is how do you integrate the genetic and non-genetic risk factors to create that overall understanding of risk? So we call these integrated risk tools, but other people call them by different names. But it's the idea that there's a bunch of things that you can measure, and in fact, a lot of clinical practice is already measuring and using it as the basis on which to make clinical judgments and clinical decisions around risk, but where we can kind of throw PRS into the mix. We can say, you're measuring all these things, you're using risk anyway, hey, why don't you use PRS in this context too? So we call these integrated risk tools, or IRTs. And the idea is pretty clear. It's illustrated on the bottom. Sorry, the color's a bit faded. But here we're looking at the risk profile, the 5-year risk of breast cancer in this case, for women stratified by age. So there's an average, the red dotted line. And essentially that's the only information that's used today beyond carrier status for women in the UK. but the blue dots show blue to cyan show the spread around that we can measure today from including PRS. And you can see there's a huge spread. So the idea is that you can measure absolute risk over defined intervals, because it's absolute risk that typically drives clinical practice. We can throw PRS into the mix. We can get an updated understanding of risk. And we can feed that back into the clinical pathways where that risk is already being used. So, for example, in the UK, there are various risk calculators like QRisk for cardiovascular disease, PCE in the States also for cardiovascular disease, and there are various diabetes scores that are used in different places as well. So these are non-genetic risk scores. We've worked out how to take those, get the genetics, throw it into the mix, and come up with an updated risk score. So this is pretty sensible. The idea is you've got practice using risk, why don't we just add genetics? Clearly what you need to do to demonstrate that this is an appropriate thing to do is to demonstrate that these tools, which calculate what's your chance of getting this disease over a defined interval, have the right calibration. And so we do lots of work to create plots that you see on the top right. This is a calibration plot which compares, in this case, I think this is breast cancer risk in this case. It compares the predicted to the observed risk for people in different risk buckets. And what you want to see is that the blue points fall along the y equals x line, so which they do in this case. And if they're off the line, then you've got poor calibration. So this is the kind of evidence you need to generate that these integrated risk tools, the predictions of absolute risk, are well calibrated, that they're giving the right numbers. So if you can do this, what you end up with then is a sort of a better understanding of risk in a population. As I said, in the UK, cardiovascular risk is already measured using QRisk. So what you can imagine doing is taking those people around the threshold for intervention. Here the intervention is statin prescription. So you can take people around that threshold, which is 10% of risk over 10 years, throw in genetics, and you can see that spreads our understanding of risk. You get a more refined distribution. Some people's risk shoots up, some people's risk goes down. And so we can think about the sort of the reclassification, how many people who weren't at risk now become at risk, or vice versa, or what sort of magnitude change in risk do you achieve. And the levels that we get, sort of the net reclassification, is in the sort of early teens, 12% or so. And that's pretty impressive in terms of the impact that they might have on clinical practice. Okay, so what I hope to have covered in that is the idea that, okay, the science is strong, but if you want to include it in clinical practice, then you have to look at the places where risk is already being used and to throw genetics in the risk. Don't pretend it's something totally new and you've got to throw everything else out, but rather more gradually introduce it in on top of what's already being done. So now I want to come on to that really thorny problem, which is really gets a lot of attention in the field, and rightly so, because it is a problem, which is around the relationship between genetic ancestry, which correlates strongly with self-reported ethnicity or race, and the performance of these tools. And the criticality that there is that the type of, the tools that we're generating in this field reduce inequalities rather than exacerbating them. Most healthcare systems have a fiduciary duty to avoid doing things which increase health inequality, obviously. You don't want to do that. So that's been a challenge for the field because it's well known that the performance of PRS, or the extent to which that we as a field understand the nature of risk, varies by genetic ancestry. Basically, just because most of the studies have been focused on European ancestry populations. There are other questions around whether there are systematically different genetic architectures, certainly for some traits, which is a secondary thing, but also very important. But fundamentally, we have to be offering tools and technologies which are reducing health inequalities rather than exacerbating them. And it's a problem that's not just found in genetics. These are examples from fields of AI or other types of diagnostic, where there have been really exciting developments in the field, but when you actually roll them, you start testing them, do they work equally well for everyone? You find that that's not the case, and often they can actually be, even worse, they can be systematically biased as well. You can systematically over or under-diagnose, for example. So it's a genuine problem. And it is potentially a problem in the field of polygenic risk, because if, for example, we flagged 10 times more people as being at risk for breast cancer who were white compared to black, that would be problematic, because you wouldn't be getting people into those screening programs in a manner that reflected underlying actual rates of breast cancer. It's probably a long way. We're probably a long way off having genuine parity in terms of PRS performance by ancestry. We may not ever even get there. Who knows? But that doesn't mean to say we can't construct tools and technologies which don't exacerbate inequalities and, in fact, act to reduce them. I just want to give you one example. This is a case of prostate cancer where we have a very strong PRS. It's well known that prostate cancer is one of the easiest to predict diseases from the point of view of PRS, and there have been lots of studies on it. Now, what you do with that prediction is a whole separate topic, and in the UK and the US you have very, very different views. But let's assume that you want to know that you're at high risk of prostate cancer. Now, the prostate cancer PRS is more powerful in people of European ancestry than black ancestry. Oh, I'm sorry, black race or ethnicity. And that is a problem because actually the rate of prostate cancer in individuals who report as black is 70% higher than people who report as white. So there's a baseline difference in rate between the populations, but if we just identified people as being at high risk because they had an odds ratio greater than 2 or something, we'd flag many more white people than black people. Now that's a problem, and we shouldn't be doing that. That will only exacerbate health inequalities. But what if we take this approach of saying, well, let's take the baseline and we'll use the genetics to modulate that? What does that do? Well, it turns out if we take that approach, then the resulting IRT, these integrated risk tools, which is essentially your absolute risk of getting prostate cancer over the next X years, it turns out that that tool flags twice as many black men as white men as being at high risk. So you've gone from a setting where the underlying PRS has very differential performance, it's better in whites than blacks, but actually, if you factor in this difference in baseline and you build it into your essentially absolute risk prediction, then indeed you can get to a point where it's a more powerful discriminator. It identifies more people at risk in that black community. Now, this isn't ultimately good enough. We need to get to a point where we've got a much better understanding of genetic risk in black men. But it's now at a point where the technology at least meets that bar for saying it will reduce health inequity rather than increase it. Now, that's not true for every risk tool. There are some risk tools which we have not tried to roll out because you don't meet that bar. When you sort of, even after you've factored in the baseline, you still are not reaching that sort of parity in terms of number of people that you flag. Okay, I now want to finish with a couple of vignettes about actually how we have rolled out these technologies in real-world situations. So everything up till now has kind of been the science, essentially, the underlying science. And I want to look at 2 studies that we've done, one in the UK, one in the US, where we've taken these technologies and put them in the hands of people who might use them. The first of these is a study in the UK, which was an implementation study looking at whether we can integrate PRS in the routine care of cardiovascular disease within primary care. So in the UK, we have something called health check, which when people hit about 40, they get invited to a conversation with a primary care practitioner or GP, where they have a conversation about cardiovascular disease, amongst other things, and the GP measures a bunch of things about them, height, weight, smoking behavior, and so on, LDL, and there's a prediction using this Q-risk algorithm as to their probability of getting cardiovascular disease over the next 10 years. I've already said that we've worked out how to take PRS and throw that into the mix. So the study we did was to say, well, can we take clinicians or GPs who are already doing this, and then just integrate PRS on top of that? So we did a study with the Northeast Commissioning Support Group based in the north of the UK. We recruited a bit over 800 individuals who were going through this health check across 12 GPs. Now, these GPs are not specialists in genetics by any means. They're people who are interested and wanted tools that could improve the conversations with their patients, but they're not specialists at all. We did provide training, we provided support, of course, but fundamentally these people did not, for example, have clinical genetics training. So we were interested in the question of, could we do this successfully, essentially? It was called the HEART trial. And of course, what you find when you do this is that if you look at risk derived from things that are already being measured, so Q-risk on the x-axis, and then the integrated risk on the y-axis so this is sort of after you've put genetics, before and after you've put genetics in. You can see the spread. There are some people, when you add genetics, they go from low risk to high risk. Some people who get down-classified moderate risk, they get sort of pulled below the threshold. Actually, it turned out that a group that was very interesting and the clinicians found very valuable were people who were above the threshold, but who were a bit resistant to taking statins. But when you added genetics, their risk went up quite a lot. It turned out that that conversation was much easier to have if the GP could say, you know what, your genetics says you really are at high risk, you should be doing something. So overall, it was a pretty successful trial. Over 90% of the GPs said that they found the integration pretty straightforward. In 13% of cases, did the GP say the information would change their management of the individual, and the vast majority of the people who were receiving that information, the participants, 87%, said they were likely to recommend it. So it was pretty positive. And the way we did this was essentially to provide a report for the GP that looks like the thing on the left that says, before you had genetics, this was the risk that we would have calculated using Q-risk. Once we bring in the genetics, that has now changed your risk, our understanding of your risk to this. So that's the way in which the information was provided. And it turned out, the chart on the right, that when that gap was quite substantial, and typically up and upwardsly substantial, so quite a lot higher risk from including genetics from without, then in about 50% of cases that the GP changed the management or found that it was an easier conversation to have with the patient than otherwise. So it was about 24% of patients had a sort of significant change in understanding of risk on the basis of including the genetics. And that case, or those cases that I mentioned of going from high-ish risk to really high risk, turned out to be the ones that the GPs felt were the most impactful. So that's a study in the UK putting the information in the hands of GPs. not specialists, as I said, but people who are managing populations of individuals based on their risk today. And that's obviously true in cardiovascular disease, but it's true in all sorts of different diseases as well. Wherever there's a screening program, essentially, that is effectively a risk-based decision about who to screen, or the screening age ranges. There are some parts of the world which are thinking about more tailored risk-based screening, even within an age range. For example, in bits of the UK, or bits of the screening programs within the UK. So we see that as a really exciting avenue for getting the information in the hands of people who can use it. But the final study I wanted to mention is where we're putting the information about risk not in the hands of a GP, but in the hands of individuals themselves. So we're saying to you, this is your risk of getting this disease. And this feels like a sort of direct-to-consumer thing. Actually, we're not selling to consumers. This is a partnership with a big US company who are offering this as a sort of something to the people that they manage. So the idea is that you can receive information about your risk based on your genetics, and you get it through a web app or on your phone. And what we've developed is a product that does this. It doesn't do it for all the diseases, for precisely the reasons that we need to align recommendations about what to do on the back of this information with clinical guidelines, which time windows, which segments of the population, and so on. We've got to be able to address the fact that we know that there are differences in baselines between segments of the population, age, sex, ethnicity, race, and we have to be able to offer actions on it which are safe, evidence-based, and accessible. And off the back of that, we've chosen these 8 diseases that we're working, 8 traits, some of which are diseases, some of which are important traits off the back of it. So we've done a study, again with about 1,000 individuals, where we offered this up to individuals as a simple sort of sign-on service. You got an email inviting you, you clicked yes, you registered, kit was sent. This is a saliva kit. You had to fill in some information. It was a clinician-ordered service. So we have a healthcare practitioner ordering the test and mediating the return of those results. There was the opportunity for a discussion with a clinical geneticist if the individual wanted that off the back of it. And we ran this in a relatively short space of time last year. And the good news was that people found the information valuable and helpful. The number that's kind of the most important, I think, is the one on the top right, which is 72% of people felt that off the back of this information, they wanted to do something about it. They'd learned something useful, they wanted to take that on. Now, we haven't proved that they have taken that action. That is clearly something we need to do in the future. But a lot of people were saying they wanted to do something. I also think the 6% is also a really important number. 6% of people took up this offer of free genetic counselling. It's a pretty small fraction. So most people didn't feel that they needed a professional to help them understand this information. And actually, I think this is almost the most important thing, is that when we dug into the details of that feedback process, we found that on the whole, for the vast majority of users of this, the information that they were receiving, they were feeling gave lots of value. They had low anxiety about the information, even though it was about things like cancer in some cases. And they felt that the information that was provided was enabling them to do something off the back of that. As I said, we have yet to prove that they do anything different off the back of it, but everything is pointing in a good direction. Okay, so those are the vignettes I wanted to talk about. Just where is this going next? Well, within the UK, we're very excited to be partnering with Our Future Health, which is this flagship program to recruit 5 million people Genomics PLC is going to be providing risk tools, PRS and the integrated risk tools, to that project, and will be very much involved in designing programs to provide that information back to participants. So it's a really exciting step forward within the UK to see how this information can start to seep into society at a genuine population level. 5 million people is 1 in 10 people essentially in the UK. So we are starting to see that transition from PRS being a niche within an academic sphere to something that is genuinely making inroads into society at large. It's been very exciting to get to this point, and I'm sure the next few years are going to be equally exciting. With that, I shall shut up and take any questions. Thank you.
Thanks very much. We've got some time for discussion. Let's start in the room at the mic.
Hi, my name is Keenan Mokbil. I'm from University of Exeter. I just have one question. Thank you for the talk. Are there any tools based on polygenic scores that could be used for prognostications? Like in the clinic, like we know genetics, like genetic tools like EndoPredict, or the ones that incorporate clinical pathological factors like epiclin, or they are very helpful to recommend chemotherapy or to forego chemotherapy. Could those polygenic risk score be used in such kind of very informative tools? So very helpful in the clinic. Thank you.
Great question. So I think there are two components to that. One is I very much focused on risk, but of course risk is just, it's one trait. Benefit is another. And it's kind of the opposite of that. What will you benefit? How will you benefit from a particular treatment? And then there's another domain which is sort of more differential diagnosis. Can you help me work out whether this person has this disease or that other disease? And there's also a broader program of integrating with information around, say rare mutations, you've got your genome, or possibly even somatic mutations that you have in a cancer. I think those are absolutely all part of the program of using genetic risk to improve healthcare. I think there is evidence pointing to that genetics, PRS, can be important in each of those domains. I think the evidence base is better in some areas than others, and typically the evidence base around treatment benefit is not there today. I strongly suspect that as the data become, the genetic data become more pervasive in society, we will learn a lot about how to use genetics to make better recommendations about treatments, whether to accelerate to treatment B versus the frontline treatment, for example. Whether this person's likely to respond well to this immunotherapy versus that immunotherapy, absolutely. But you need the genetic data to be really pervasive before you can start doing that work. I think where that will start to become more apparent is in clinical trials. I think as pharma develop drugs, there's going to be much more emphasis on using this information upfront within the study to work out who is responding well, for example, to a drug. So you do that stratification at the design stage rather than post-hoc.
Yeah, I think sorry, the genes are actually in EndoPredict, for example, the 12 genes are in genes associated with progression and
yes, okay.
and kind of like angiogenesis in cancer or tumors, which are not related actually even to treatment, but they are used like as a proxy. So if we can use some variance from survival rate in patients and correlate those ones as polyrisk score.
I'll come and find you after
Yes.
and talk more. I can see there's a line out behind you. Yeah. Thanks a lot.
Hello, Nick Klein from Sanger Institute. Thank you for a great talk. I was wondering, when you're reporting these risks back to users in your app, how do you deal with the kind of uncertainty that you have in your prediction? Do you report back kind of, because you have your 70% increased risk of a certain disease, but I guess there's quite a lot of uncertainty around that, and do you report that back? And how do users deal with understanding what this uncertainty in the risk is?
We report a number, a single number. We don't give an interval of, your risk is somewhere between 3% and 7%, because that's not how I think about the problem. Our scores are well calibrated. So if I say you're at 10%, you are at 10%. Now, within that, I fully acknowledge there are some people who are at 15%, some who are at 5% because of things that we haven't measured. But without having measured those things, I can't know about them. Mm. So the statement that your risk is at 10% is a well-calibrated statement. We do say things like, we haven't measured rare variants. So, if it turned out you were, say, very low risk for breast cancer, you could still be a carrier of a mutation in BRCA2, for example, and which we haven't checked. So we do say very much there are things that we have not measured here which could change an understanding of risk very substantially, but we don't try and report an interval, for example, of that risk.
Could I probe your statement about calibration? So you showed a very nice calibration plot. Was that within UK Biobank, sort of in an independent set from where you trained the model?
That was a UK Biobank, and we used no UK Biobank data in training that model.
Right, okay, so that, yeah, I mean, because sometimes people will show these things where you kind of show a calibration from the other half, which is just showing your random number generator
that
works.
Count.
Yeah.
Yeah.
But I would also say that, I don't know which data sets you're using, but those calibration statements can vary a lot from place to place and even time period to time period. And even the extremely well-known things, the pooled cohort equations, et cetera, don't calibrate in absolute risk, from the US to Canada from 1970 to 1990.
Is not well calibrated.
Sorry?
PCE is not well calibrated.
Yeah, but I mean, it seems like it's a big statement that it's well calibrated everywhere. The absolute risk estimate is well calibrated because. So
we test the calibration everywhere that we have the relevant data to test it. Some of them are better calibrated than others. That was obviously a beautiful one to show.
As one does.
But we would never roll something out where we didn't have a fully independent data set to demonstrate that calibration.
Great.
Liz Worthy from the University of Alabama, Birmingham. I was just curious whether you found any examples of where adding the genetic risk to the existing risk lowered an individual's risk, and whether you looked for that, what you did with that. So
if you take the heart study, then 50% of people will roughly end up with a lower risk once you've included their genetics, because it kind of would use it to spread the distribution. So we very explicitly did not say to anyone, you were at high risk, you're now at low risk. We didn't think that was a good idea for obvious reasons, and we would never recommend anyone to stop taking a medicine on the back of this information. So it's really just being used to up-classify people. Find people who were previously, who didn't know they're at risk, who are now sort of clearly at risk. So that's where we are today, and we're not intending to move away from that quickly. I do think there is whenever I talk to, for example, people who run screening programs about this, they do say, you know what, that could be really interesting, because you don't stop screening people in the low-risk group, but you might offer it slightly less frequently, or you might chase people slightly less about attending screening. So I think there are ways. I think you have to be careful about saying you're at low risk, because kind of for the reasons of the previous question, you don't ever know you're definitely at low risk, but you can use it to modulate things in a more quantitative way than a binary way, that should allow healthcare systems to focus more attention on the people who need it.
It might play into the side effect risk versus risk of disease, if they're, anyway, yeah, thank you.
Okay, I think we should probably move on then in the interest of time, so thanks very much to Gil again.
Thanks.